Hello, and welcome to another podcast episode of the Think Thrombosis podcast series from medauthority.com. I'm your host, Geoffrey Barnes. I'm a cardiologist and vascular medicine specialist at the University of Michigan. And today I am so excited to have my very good friend and colleague, Dr. Sara Vazquez, join us. Dr. Vazquez is a clinical pharmacist at the University of Utah and is a former board member of the Anticoagulation Forum and is somebody I go to all the time when I have questions about anticoagulants and how to select them or how to use them. So, Sara, thank you so much for joining us on the podcast today.
Thank you for having me, Jeff. I'm excited to be here.
So I wanted to start out with sort of a broad sort of question and picture. If we're thinking about stroke prevention in patients who have atrial fibrillation, can you give us just like a broad strokes overview of what are some of our different treatment options as we think about trying to prevent strokes in these patients?
Absolutely. So we do have options now, which is a nice thing to discuss and offer with patients. We have our first line we typically go for is direct oral anticoagulants for stroke prevention. There is also warfarin. And then for patients who may not be suited for long-term anticoagulation, we can consider procedures to occlude the left atrial appendage.
That's really helpful. So as we think about those three big groups, we obviously have the non-pharmaceutical one, which is the mechanical occlusion of that left atrial appendage. But could you walk us through maybe a little bit of the differences between use of the direct oral anticoagulants, which I know include our direct thrombin inhibitor, dabigatran, as well as those factor Xa inhibitors, apixaban, rivaroxaban, and edoxaban, and maybe what's similar or different from them as compared to the vitamin K antagonists like warfarin that we use?
Sure. And I think it's important to start with how good of a job do they do at preventing stroke. That's our ultimate objective is with any choice of these therapies that we make, our objective is what achieves the best stroke prevention for this patient while minimizing the risk of bleeding adverse effects. And so to begin with, from our clinical trial data, we know that the direct oral anticoagulants are at least as effective as warfarin at preventing stroke, if not better in some cases. And then they also have a potentially lower risk of bleeding compared to warfarin. So those are typically the things that I lead with when I am talking with patients or thinking about which therapy to choose.
Now, it's really important. You talked about these being at least as good. So the efficacy or the effectiveness is, really well established, but it may even be safer. Can you maybe unpack that a little more as a class? What are we talking about from that safety standpoint and what differences do you see?
Right. So in the clinical trials, they looked at major bleeding, which is something that we should all care about as well for our patients. And so when we group major bleeding all together, most of the DOACs were actually safer in terms of major bleeding compared to warfarin. And I would like to highlight that the most feared bleeding complication that is included in that major bleeding definition is intracerebral hemorrhage. And we worry about that because that's the most severe, potentially fatal bleeding complication. And to me, one of the most, I think, significant safety advantages of the direct oral anticoagulants is that to a drug, every single one in the data that we have so far has been shown to have a significantly lower rate of intracerebral hemorrhage compared to warfarin.
You make that point, and I have found that to be remarkable. As you mentioned, it's not just every drug, it's in every randomized study, most of the observational studies. Is it AFib? It's VTE, it's whatever. They're always showing this reduction in intracranial hemorrhage. And I find that to be something that's so powerful as a clinician, but also when I talk to patients. Do you find that your patients resonate with that as well?
I think they do. And I think, a lot of patients have their personal stories or their personal experiences or those of friends or family members that influence their decision making, and they know someone maybe who has had a bleed in their brain. And so when you talk about that, preventing that, it does resonate with them.
I know you actually spend a lot of your time talking with patients and helping them pick what is the best anticoagulant when they have been diagnosed with AFib and they're trying to figure out what that they do. Obviously, this efficacy and safety piece, that's a big part of your conversation. Are there other things that start to factor into that? And how do you have those conversations with your patients?
For sure. And this is probably one of my favorite things to do, actually, is to have these conversations, because it's refreshing that we do have options to offer people now when we didn't previously. And so it's a very satisfying conversation to be able to have now. So yes, in addition to, these efficacy and safety conversations, I think, unfortunately for me, one of the first things that, here in the United States, we have to talk about is cost and drug access and affordability. And is this something that we can not only get you for the first month or 2 or 3, but for the long term? And so we do talk about, cost and affordability. And then we sort of follow on with, I think it moves into what I call the convenience factors, and the potential advantages that the DOACs offer. The convenience of, fixed dosing regimens, the lack of INR monitoring that is required, the lack of dietary vitamin K interactions, and fewer drug interactions that need to be considered. So those are sort of, once we get past, I think, the top tier things like, efficacy, safety, affordability, and access, then we sort of move into convenience factors and just then go into what the patient's values and preferences are, which can be surprising sometimes. So
I agree. I find patients often will bring interesting stories that really influence their ability to make a decision, or, they really anchor on one element, right? Is it the once a day versus twice a day? Is it the lab monitoring with the vitamin K antagonists like warfarin or not with the DOACs? Is it, some patients say, you mean I can eat a salad when I want and I don't have to worry about it? That's great, right? And that can be the main driver of their decision. And I find that to be fascinating, but also really important, because we want them to take these medicines to prevent stroke, right? That's just so critical.
And I think it's interesting too, it depends on what their background is. If you're talking to a patient who is brand new to anticoagulation altogether, that conversation shapes very differently than a patient who has been on warfarin for several years, and then you're discussing, a potential switch to a DOAC. I think that conversation shapes very differently, and their perspectives are very different. And you have to have a conversation. All the time it comes up. How do I know I'm okay? How do I know I'm okay if I don't have the INR? So you have to sort of, talk them through, a completely different concept that is sometimes hard to wrap their brain around.
Well, speaking of this idea of choice, we have all of these choices for stroke prevention in AFib, but there are some patients in whom maybe the DOACs are not going to be a good choice for stroke prevention in AFib. And could you walk us through high level, like what are some groups of patients where you might still say, no, a vitamin K antagonist is really the drug that we should be using for you?
Sure. Yeah. I mean, obviously, we try, to get as many patients onto DOACs as possible for all of the reasons that we previously stated. But, sometimes it is just not, an appropriate fit for them. And so I think a lot of it comes down to their, concomitant conditions that may preclude them from being eligible for a DOAC. For example, if they also have a mechanical heart valve in addition to their atrial fibrillation, rheumatic heart disease. Those are a couple, that come to mind immediately. And, if they have, just a complete inability to afford the drug, then that is really, it leaves you with warfarin there as their only option. And that's not a clinical condition, but that's where we end up sometimes.
Yeah, I also think of the patients with antiphospholipid syndrome are ones in which we start to get concerned about the DOACs, and that's just another area to think about. I want to shift gears for the next couple minutes and say it's great we have all these options, and we often are able to get patients onto a stroke prevention regimen, right? Usually with a medicine like a DOAC or a vitamin K antagonist, but sometimes with a non-pharmaceutical therapy like left atrial appendage. But we also know there are lots of patients with AFib who are not receiving any stroke prevention at all, what we'll call undertreatment of AFib. And I'm wondering, how big a problem do you see this as being? And what are some of the things that we as healthcare providers can do to try and address it?
Right. I think there probably are some barriers or perhaps misconceptions that we can work to address in that. And perhaps it starts with us as providers really making sure that our eyes are open to assessing stroke risk and using, the CHADS2-VASc scoring system, for example, to, ensure that patients who have a justifiably high stroke risk are receiving anticoagulation appropriately. I also think anticoagulation tends to get a bad reputation sometimes. And so there's a lot of, angst about prescribing that. And I think particularly that might be the case in older patients. I think there's this bias, and this is just my personal opinion, but I think there's this bias that we worry about bleeding a lot more in older patients. Maybe they're frail, we're worried about fall risk, and that might be a bias in our part or a barrier to prescribing anticoagulation. And we forget that stroke risk also increases with age. And so I think it's really taking each patient individually and thinking through the balance of that and not necessarily defaulting to withholding anticoagulation in those patients where, yes, we might be concerned about bleeding, but should we also be equally or more so concerned about their stroke risk? I know for some providers and some patients for a while, one reason for, I think, withholding anticoagulation might have been concern about the lack of reversibility with the DOACs. And so I think now that we have, reversal agents for these drugs, that has, sort of ameliorated a little bit of that anxiety and withholding anticoagulation when we know in our minds there's something that can be done about a potential bleeding event.
Yeah, I think a lot of what you talked about really gets at two important groups that are being undertreated. The ones where maybe we're not even thinking about it, right? We haven't even realized that they have AFib or that they're at increased stroke risk. And, there's lots of population health tools and EHR tools that are being designed to sort of help make us more aware. But also there's that group where we know, yet we as clinicians are choosing not to offer because we're afraid of the risk, or patients are saying, I'm not really concerned about that. And that takes a lot of education, a lot of time to go through that shared decision-making conversation. And I think that's so important to do. But then there's a third group, and that's a group that of patients who maybe were treated. They were on an anticoagulant for AFib, and then they experienced some sort of a bleeding or a bruising issue. And now all of a sudden we throw up our hands and we say, no, we can't do it anymore. And one of the things that I often talk about, and I know you do this regularly, is you look for ways to reduce their bleeding risk, right? And I'm wondering if you can talk about how do you screen for maybe concurrent NSAID use or aspirin use or some of those other things that contribute to bleeding risk that we could address and get them back on their anticoagulant? What are some strategies that you employ?
I think that's a great point. And actually, I think this is a great opportunity to use the HAS-BLED score to really assess what bleeding risk factors does this patient have. Some of them I can address
Yep.
Some of them are just not modifiable, like their age. But some things I can address, if they have hypertension, is that well controlled? Are they getting a concomitant, nonsteroidal anti-inflammatory drug that might increase the risk of bleeding? Are they on aspirin and they don't really need to be? I think those are probably the highest impact bleeding reduction interventions that we could possibly make for these patients. Other things would be, to assess alcohol use, their prior bleeding risk, GI bleeding risk, for example. Are there ways that we can help to mitigate that? So I'm kind of walking through that kind of list of things in my mind, and those are tangible ways that we can, show patients that, hey, we're doing everything that we can to minimize your bleeding risk so that you can experience the benefit of anticoagulation in terms of stroke prevention.
Yeah, no, that makes a ton of sense. The last question that I get sometimes, and I'm wondering if you do as well, and if you do, how you respond to it, is people say, well, the anticoagulant, I had a bad experience, or maybe I'm scared. I've heard of somebody that had a problem. Can't I just take an aspirin? Isn't that going to be good enough? Do you hear that? And how do you respond when people say, can't I just use an aspirin instead?
Yes, I hear this all the time. I think from both patients and providers, we're like, oh, a little bit will be good enough, and I think that I understand where that's coming from. And I think the logic is there, but unfortunately the data don't bear that out. We do have data from the Averroes trial. From several years ago when apixaban 5 milligrams twice daily was compared to aspirin in patients who were actually in this category that you're exactly describing, Jeff, who were considered to be, quote, unsuitable for warfarin therapy. And, apixaban the trial was actually stopped early because apixaban was so dramatically superior in terms of stroke prevention compared to aspirin. And it didn't increase the risk of bleeding compared to aspirin, which I think is very impactful. And so the message to patients that I give is I understand, where that would be a logical, thought process or alternative. But in fact, it doesn't provide you enough or sufficient or good enough stroke prevention, and it actually contributes quite a bit to your bleeding risk without giving you that benefit. So I don't offer, aspirin as a, sort of second tier alternative, if you will.
Yeah, and the guidelines also, I think, have that same approach. Aspirin is not a stroke prevention therapy for our AFib patients. We really need to be looking at anticoagulation or a mechanical option like left atrial appendage occlusion. So I think that's great. Well, I want to go back and summarize because I think you have raised so many great points that I'm going to take home with me and really think about. The first is that we have options for stroke prevention in AFib, and that's great. It's an awesome spot to be in, to be able to talk about vitamin K antagonists, the direct oral anticoagulants, and the non-pharmacologic options like left atrial appendage occlusion. And that when you talk with your patients, your first line is usually one of the DOACs, so either the direct thrombin inhibitor or a oral factor 10A inhibitor, because they're at least as good, if not better, at stroke prevention than the vitamin K antagonist, with probably less bleeding, especially less intracranial hemorrhage. And that's really important. And so you talk about some of the benefits, some of the convenience factors as you're trying to help patients make those decisions. But then you also recognize that sometimes we have this population of patients that are being undertreated. And so we need to do a better job of recognizing the stroke risk elements. And you talked about the CHADS-VASc score being the most commonly used one. We also talked about patients who've maybe had bleeding complications. And so using the HAS-blood score, not to decide if you'll anticoagulate, but rather to find those modifiable factors, things like addressing hypertension, deprescribing NSAIDs or aspirin as ways that you can minimize bleeding risk and get them back on a stroke preventative therapy like an anticoagulant. And then, of course, really highlighting that aspirin is not an acceptable stroke prevention therapy. We really need to be looking at our anticoagulants or something like a left atrial appendage occluder as a way to try and make sure that every patient who's at risk of stroke is getting some sort of a preventive therapy. Anything to add to that summary that you think our listeners need to hear?
No, I think you summarized and covered all of that really well, Jeff. Thank you.
Awesome. Well, Dr. Vazquez, thank you so much for joining us. This has been an awesome discussion. And to all of our listeners, thanks for being here with us on this Think Thrombosis podcast from medauthority.com. We look forward